Welcome back. I'd like to go ahead and start this latter part of the afternoon or morning session. I've been to a lot of conferences and medical meetings, and Friday morning and Friday afternoon sessions tend to lack in attendance, and I was really pleased to see what we had in there and what we have here so far, so I commend you and appreciate your support. The rest of this morning, we're going to be privileged to hear from the residents at McKay-Dee Hospital. They'll be going in alphabetical order. We'll hear first from Aaron Anderson, followed by Courtney Ladica, Ben LaRose, Carissa Monroy, Chuck Richardson, and then Jesse Spencer. We also would like to invite these residents to tell us who they are, where they did their training, and also where they're going, because I believe many of them are on their way out into bigger and better things. So with that, we'll go ahead and start with Aaron Anderson. Yeah, one other housekeeping item. We're going to go ahead and reserve all questions until the end. The residents will go through their 6 talks, and then at the end we'll have a half hour or so for questions, and we'll invite them to come up and sit here as a panel for those questions.
Thanks, Dr. Allen. Like he said, my name's Aaron Anderson. I'm one of the third-year residents at McKay-Dee Hospital. I did my medical school at University of Cincinnati and came out to McKay-Dee for residency, which is kind of where I grew up. And in roughly 48 days and 7 hours now, we'll be finishing up with residency, and I'll be moving on to be the fellow for sports medicine up at Boise State. And today I want to give, my lecture is going to be on simple concussion versus traumatic brain injury. And I want to start off by saying I don't have any conflicts of interest, full disclosure, and I did receive permission from this particular patient to give this case presentation, but I will use a different name. We're going to call him Todd for the sake of this presentation. Todd is a 20-year-old football player at Weber State University. He plays fullback, and just a little bit of past medical history on him. He was diagnosed with Hodgkin's lymphoma in the summer of 2010, just last summer. He did receive treatment for this, which consisted of radiation therapy 5 times a week for 5 weeks, which he completed in the fall, just this past fall. He did very well after. He was cleared by his physician to play football and played throughout the fall. In the spring, just 2 months ago, he sustained a helmet-to-helmet contact injury during practice. He was seen immediately afterwards by the training staff at Weber State and had no loss of consciousness at the time. He did complain of symptoms of headache, dizziness, sensitivity to light, and noise, as well as some later complaints of fatigue and difficulty concentrating. He was seen by myself approximately 4 days post-injury and had the main complaint of a severe persistent headache, which was unremitting. He was taking quite a bit of Tylenol, max doses of Tylenol and ibuprofen, but had no improvement in his headache symptoms. On examination, he had no focal neurological signs, but was obviously in quite a bit of pain, more than what you would expect. And he did explain this as the worst headache that he had ever had. He had impact testing, which is part of the Weber State protocol for concussed athletes, 48 hours after his injury, and we'll go over that a little bit now. I wanted to talk about the assessment of concussions. Sideline assessment of concussions differs a little bit from what we do in the emergency department or what we do in the office setting. One of the tools that has come about for testing for concussions is the SCAT-2, and this acronym stands for Sports Concussion Assessment Tool number 2, which is updated from the version in 2005. It's a great tool, and it can be found on iPhones, iPads, and lots of different electronic media, as well as paper format and cards. And this can be administered fairly quickly on the sideline and can be helpful in the office setting as well. What it does is it goes over symptoms using a symptom scale that the patient fills out. It includes the GCS coma scale, Best testing, and this is a balance error score assessment, and this assesses the patient for balance errors. The patient is tested with his feet together in a tandem stance and then on one foot with his eyes closed on a firm surface and then later on a foam pad. And this is done serially to assess for the patient's balance. It also includes physical signs, which includes loss of consciousness at the time of the injury, memory recall, and coordination with finger-to-nose testing. And so this can be a very helpful tool, especially on the sideline for evaluating these concussed athletes. The impact test is a computer-based test, which many of you may be familiar with. IMPACT stands for Immediate Post-Concussive Assessment and Cognitive Testing. It takes about 20 to 30 minutes to take, and most athletes in this area, high school athletes and college athletes, are given this test pre-season to have a good baseline. It's repeated after the concussion, and it measures attention span and working memory, response variability with different questions, and reaction time, and generates a very objective score to help and determine the cognitive deficits that are left over from the concussion. So he received both of these tests, and his impact testing was abnormal, suggesting that he did have some concussion. So some of the complications that can arise from a blow to the head, post-concussive syndrome, which is another way of saying the symptoms from a concussion, is very common. We also have to worry about skull fracture, bleeding, such as subdural and epidural hematomas, and subarachnoid hemorrhage. And all of these are kind of the immediate complications arising from a first-time blow to the head. There are some complications that can occur from repeated blows to the head, such as second impact syndrome, which is a devastating syndrome resulting from a repeated blow to the head after a first concussion that's unhealed. This can result in severe brain damage, coma, or death. Dementia pugilistica, which is what we call punch-drunk syndrome, or chronic encephalopathy, resulting from repeated blows to the head as well. In the long term, there is an increased risk of epilepsy and about a 5 times risk of developing Alzheimer's disease after 3 blows to the head. So in some of these patients, we wonder, when do we image a concussed athlete or a concussed patient? And there's some debate on this, and some of this is subjective, but kind of consensus from the literature shows that if there's any loss of consciousness greater than 5 seconds, and that if there's a 4-second loss of consciousness, probably not a big deal to image that patient either. So really any significant loss of consciousness, you should consider CT or MRI imaging. Concern for skull fracture, obviously. Any evidence of a focal neurological deficit or worsening neurological function, and this is where it kind of gets into some subjective testing. Worsening symptoms can also warrant imaging, and in our patient, Todd, who had worsening, persistent severe headache, we decided to go ahead and get a CT scan. This is actually his CT scan, and looking at the images, moving up, you can see that there is focal enhancement along the left temporal and cerebellar lobes. Kind of most prominent, you can see it right here, representing a subdural, somewhat subtle subdural bleed. All of this resulting from a first blow to the head. And you can still see this evidence of subdural right here. So this patient had a subdural hematoma, which we all know results from tearing of the bridging veins and a collection of blood in between the dura and the arachnoid. It comes in 3 different flavors. Acute, which is an immediate large pooling of blood in this space. This has a very high mortality rate, on the order of 60 to 80%, depending on the study that you cite. There is also a chronic version of this, which results from minor trauma to these veins, and the bleeding progresses over days to weeks. It has a fairly good prognosis, with 80% of people having no residual symptoms or a very good outcome. There's kind of an in-between or subacute pattern of subdural bleed, which happens over hours to days and can result in moderate to severe symptoms. And the mortality rate on this really depends on the extent of the bleeding over these days. This patient also suffered from a concussion in addition to his subdural bleed, which left him with the residual symptoms that he had. And exactly how common is concussion? Well, it's extremely common. It's estimated that between 1.4 and 3.6 million concussions happen per year, and most of these are at the high school level and not necessarily, let's go back here, not necessarily the ones that we hear about with Cutler and Tebow. But football players are at the highest risk, just given the nature of their sport. It's historically underreported. There was a resident last year who did a study, Dr. Flinders, who took several northern Utah high school students, athletes, and administered a questionnaire to them, asking them to report their symptoms in a confidential way. And it was shown that they were grossly underreported for multiple different reasons. And this presents a problem for us as primary care providers in that we need to make it safe for these athletes to report their symptoms to us. Athletes in contact sports have approximately a 10 to 20% risk of developing a concussion per year. And loss of consciousness really only occurs in about 10% of these patients. We were actually talking about this just the other day in sports medicine clinic, and Muhammad Ali, Dr. Sherman asked me how many times Muhammad Ali actually got knocked out. I didn't know the answer, so I looked it up, and it's actually 0 times that Muhammad Ali got knocked out. He fought in 61 fights. 4 he was beaten by decision. One of them was a TKO in which he withdrew, but actually had no loss of consciousness knockouts, and still ended up with quite a deficit. So what exactly is a concussion? It results from multiple different forces acting on the brain. There's contact and inertial forces, or the coup and contra coup blows, but most of the damage is actually done from the rotational or shearing forces that happen to the brain. These cause quite a bit of damage on the cellular level. This results in an elevated intracranial pressure, as well as decreased cerebral blood flow. And the cerebral blood flow can be decreased up to 50%, which is not as significant as the 85% required for ischemia, but still fairly significant. And this is kind of a boring slide, but I'll make it a little more colorful here in a minute. And I just wanted to go through some of the cellular, the metabolic problems that happen from a blow to the head. The first thing that happens is that there's a nonspecific depolarization of the membrane. There's a release of excitatory neurotransmitters, which results in an efflux of potassium out of the cell. And this is a pretty massive efflux of potassium. The sodium-potassium channels are then activated, and this is to maintain the homeostasis of the cell. And this requires a lot of ATP. And we can only get ATP, well, we get most of our ATP from glucose utilization. And all of this results in lactate accumulation and eventually calcium influx into the cell, which decreases the oxidative phosphorylation in the mitochondria and results in a cellular energy crisis. So we have increased energy utilization by the cells and decreased cerebral blood flow, which leads to this massive energy crisis, resulting in the symptoms that you see in concussion. Those symptoms are divided into 2 main groups. The ones on your left are known as the migrainous symptoms of concussion, and they are headache, pressure in head, neck pain, nausea, vomiting, dizziness. And these typically occur fairly immediately after the initial injury. There's a bunch of other symptoms that are often very subjective, such as don't feel right and feeling in a fog. And these can persist for days to weeks, quite a while after the concussion. And it is important to note that many of these symptoms can show up hours to days after the injury. And so when do we get these athletes back into play? It's been decided, there was a conference in 2008 in Zurich where they came up with a graduated return to play protocol. And this includes 5 different rehabilitation stages to get these athletes back into competition. The stages include a period of mental rest and physical rest until the patient is asymptomatic. And it is also important to note that until the patient is asymptomatic or athlete is asymptomatic, they're not going to begin this protocol. When they are asymptomatic and they're, in our case, when their impact testing is back to normal, we begin this gradual return to play, which includes light exercise, more sport-specific exercise, and then strenuous, full contact, and then eventually they return to play. Our patient isn't going to be doing this for a little while. Todd had a neurosurgery consult, and it was decided that he would not be a candidate for surgery. His bleed was subtle enough that we decided that repeat CT scan would be enough to warrant or to watch this patient. It is important also to serially monitor him for worsening of his symptoms so that we repeat that CT scan earlier if needed. He was removed from classes for the spring semester and actually returned home to live with his parents. He is sidelined. He won't be playing any football or practicing until the fall because of his bleed. And he is doing well. I spoke with him very recently, and he's feeling quite well and excited to get back into playing when the time comes. In conclusion, I just wanted to talk about, and I'm sorry for any Cubs fans out there, in conclusion, we really need to take these concussions seriously. It's important to seriously follow up, even on a daily basis, if necessary, for some of these athletes and patients that are concussed. And imaging can be an important tool given in certain circumstances with some of these patients to rule out any other concerning disease processes. Thank you for your time. These are some of my references, and I'll pass the time on to Carissa, or Courtney, I'm sorry.
Good morning. I'm Courtney Latica. I'm from Pennsylvania. I did my training at Wake Forest University School of Medicine. And next year, I'm going to be headed to, these upcoming months, I'm going to be headed to Northern California. So it's my pleasure to talk to you about a topic that I find quite interesting and I think is a very important topic, and that's medical marijuana, why it makes sense and the laws don't. So first, I do not have any conflicts of interest, not receiving any monies from anyone. But as I stated previously, I will be moving to Northern California, specifically Humboldt County, which is the second leading producer of legal medical marijuana. So this is most certainly something that I will encounter in my private practice. So what I hope to cover today during this talk is medical marijuana, who supports it, how it works, including the endocannabinoid system, its indications, toxicities associated with its use, its addictive potential, and its various routes of administration. So who's using marijuana? Recreationally, about 40% of U.S. citizens U.S. people living here, age 12 and older, are using marijuana. This is greater in some places, probably California, and less in others, like Utah, most likely. And in 2009, this was the most widely abused recreational drug in the United States. There is some conflicting evidence as to whether now that's been overcome by prescription drug abuse, but still it's probably the leading drug abused. And this is, of course, much to the chagrin of the DARE program and Nancy Reagan's Just Say No campaign. As far as medical marijuana is concerned, here's a listing of the 12 medical marijuana states in 2009. Currently, there's 15 medical marijuana states. But as of 2009, these 12 medical marijuana states had a total of around 270,000 registered medical marijuana patients. Now, for each medical marijuana patient that was registered and was a card-carrying medical marijuana patient, there are likely many others at home that were using marijuana to treat their various ailments without their physicians knowing about it. Here's a map of the United States demonstrated in green the states that have medical marijuana legislation on the books. There are 15 states, including the District of Columbia, that currently allow for medical marijuana. The states in gray are those with pending legislation. This also hopefully demonstrates that medical marijuana is no longer a fringe concept, but is becoming more and more accepted in this country. So what about medical associations? My academy, the Academy of Family Physicians, is in support of medical marijuana, as is the internal medicine group, the American College of Physicians, along with the American Society of Addiction and the National Cancer Institute. Now, there are other organizations that are in support of medical marijuana, but I just listed the biggies. So what about public opinion? Public opinion is also largely supportive of medical marijuana. These polls were taken between 2005 and 2010. As you can see, there's somewhere between a 60 to 80% approval rating of the public. How about the presidential opinion? He's obviously our chief executive officer, and he is bound by federal law. Medical marijuana is not permitted by federal law, but he has decided that it will not be a priority for his administration or for his prosecutors to go after patients or their physicians that are prescribing medical marijuana under the regulation of the states. Marijuana is currently considered a Schedule I drug under DEA's classification system. The DEA thinks that medical marijuana meets these three criteria: a high potential for abuse, no currently accepted medical use, and a lack of accepted safety. I hope to show to you throughout this presentation that I think all three of these statements are false. Marijuana is made up of at least 66 different cannabinoids, including THC and cannabidiol. You can see their molecular structure shown below. We have discovered in 1992 an endocannabinoid system. This is our body's endogenous marijuana system. Much like endorphins are our body's natural morphine, this endocannabinoid system is our body's natural cannabinoids. Anandamide, shown here, the molecular structure, is the natural ligand at the cannabinoid receptor. Through our studies, we found that the endocannabinoid system is responsible for things such as appetite, pain sensation, mood, memory, and immunity. The endocannabinoid system is a robust area of research. Since its discovery in 1992, there have been many articles, and just a quick search on PubMed, you'll see that there's 4,800 articles currently published on the endocannabinoid system. So there's a lot more to come in the future. The therapeutic indications that are most widely accepted for marijuana are neuropathic pain, chemotherapy-induced nausea and vomiting, AIDS wasting, multiple sclerosis and spasticity, glaucoma, and anti-tumor effects. I want to cover some studies. First, on neuropathic pain. This was done in 2007 using HIV patients with associated sensory neuropathy. These patients both had subjective sensory neuropathy along with decreased ankle reflexes. 55 of them met inclusion criteria, and they were divided and allocated into two groups: smoked cannabis or smoked placebo. As you can see, 25 completed the study in each arm. These patients were asked to use a visual analog score, the top one, from 0 to 100 to rate their daily pain. I'll walk you through this slide. So, in the first 7 days prior to the intervention, these HIV patients with neuropathy rated their pain, and both the placebo group and the marijuana group had similar pain levels, somewhere around 60. So that's here. They were then brought into the hospital, but no intervention was done for these 2 days. There was a slight drop in pain scale for both of them. Then, while still in the hospital, they were given either smoked placebo or marijuana for this 5-day period, and again, rated their pain. This bottom line is the group that received marijuana, whereas this line is the group that received placebo. As you can see, there's a statistically significant decrease in pain in those receiving smoked marijuana versus placebo. This is a 7-day washout period where you can see that they both return to the same baseline. This is another important study that demonstrates the synergistic interaction of cannabis and opioid medications. This was done in a rat model of analgesia. Rats were placed on a surface that was gradually heated up until they flicked their tail. This tail flick was the analgesic threshold. These rats were given opioid medication and either vehicle, which was placebo, or THC. In this experiment, they gave incrementally increasing doses of opioids and did a dose-response curve. What they found is that the dose-response curve was shifted far to the left, indicated by these potency ratios, far to the left with the rats that were given both opioid medication along with THC, with the exception of the last two. So what does this mean? It means that the rats were able to have adequate analgesic control with less narcotic when combined with marijuana. This is so important to our patients because there's such a large narcotic problem in this state and in this country. Any way that we as physicians can minimize the amount of narcotics that we are giving our patients hopefully will reduce morbidity and mortality associated with narcotic medications. Toxicity. Marijuana has a low rate of toxicity. To date, there have been no substantiated deaths related solely to marijuana. The LD50 of marijuana, the lethal dose needed to kill 50% of subjects, is somewhere between 3,000 to 9,000 milligrams per kilogram. It is quite simply impossible to smoke or ingest that quantity of marijuana. In contrast to the sad statistics of narcotics in this country, I don't need to dwell on this. We've been covering this over the past 2 days. Pulmonary toxicity is probably the thing that comes most to mind when we think about adverse effects of marijuana. Marijuana smoke does contain many of the same substances as tobacco cigarettes. There's the same risk of pneumomediastinum and the same risk of pneumothorax as with other inhaled drugs. There's also an irritant bronchitis that can develop with marijuana. Let's look at marijuana and COPD. This study was done in 2009 by Juan using a large amount of subjects. These subjects were divided into 3 categories. Subjects that had COPD defined by spirometry, COPD defined by self-report, and COPD defined by self-report of physician diagnosis. And the 4 categories were non-smokers, marijuana only, tobacco only, and tobacco and marijuana. The non-smokers, obviously, in each category had no increased risk. The tobacco and marijuana smokers did have increased risk of COPD. The tobacco-only group had an increased risk of COPD, but the marijuana-only group, it's crossing 0, in all of these subsets showed no increased risk of COPD in the absence of tobacco. The American Thoracic Society also agrees with this, and in 2006 they presented a study by Tashkin that showed that people who smoke marijuana, even heavy long-term smokers, do not have an increased risk of lung, head, or neck cancers or COPD in the absence of tobacco. So marijuana and COPD. Smoking both marijuana and tobacco synergistically increases your risk of respiratory symptoms. We should be telling all of our patients that they should not be smoking cigarettes. We should particularly be telling our medical marijuana patients that they should not be smoking cigarettes. But smoking only marijuana was not associated with an increased risk of lung cancer or COPD in the absence of tobacco. Psychiatric toxicity. This has gotten a lot of press in the news lately, and there seem to be several studies that have comparable results. So this study by Arendt shows that cannabis may precipitate psychosis in patients already predisposed to schizophrenia, and it may also lead to an increased risk of persistent psychotic symptoms. Here's a study showing those studies by Arendt that shows the first age of incidence of a psychotic episode in those patients that were later diagnosed with schizophrenia. And as you can see, in both the male and female group, the cannabis group had a significantly lower age at first incidence of psychotic symptoms. But marijuana does not increase the overall incidence of schizophrenia. It just makes you younger at your time of diagnosis. So quickly, because I'm running out of time, marijuana is listed 11th on the addictive potential. This is after both over-the-counter and prescription drugs, including tobacco, opioids, barbiturates, alcohol, amphetamine. So I would just say that addiction should not be the reason that we say that marijuana is a Schedule I drug, because there's other medications with higher addiction potential that are able to be legally prescribed. Marijuana dependence is a problem. Somewhere between 1 to 17% of chronic users will become dependent on it. We need to be aware of that as providers. But I think the bottom line on toxicities is that all medications have side effects, and that includes marijuana, and we need to be aware of them. But the 1999 Institute of Medicine's report concluded that the side effects of cannabinoid drugs are within the acceptable risk associated with approved medications. Routes of administration, 4 different types: smoking, vaporizer, oral, and sublingual. Dronabinol and Nebuline are the 2 FDA-approved cannabinoid medications on the market. They're both Schedule III. Their active ingredient is THC, and their indications are as listed. They're not very widely prescribed, which I'll get into. Sativex is another up-and-coming drug that's legal in Spain and the United Kingdom. It's a 50-50 mixture of THC and cannabidiol, and it's an oral spray, sublingual. Not currently available, but in stage 3 trials. And Dronabinol and Nebuline are thought to have poor side effect profile. Often people think they're more sedating, more intoxicating than crude marijuana. Slow absorption, which I'll show you. It's difficult to self-titrate because of the slow absorption, and it's difficult to tolerate oral medications when you're acutely nauseated. So the onset of action of Dronabinol is 30 to 60 minutes, Nebuline 60 to 90 minutes, Sativex 15 to 40 minutes. Let's contrast this to inhaled marijuana, where you're getting your peak effects in 1 to 2 minutes. These are different concentrations, 2.5, 6.0, and 9.4% THC. Your peak onset of action between 2 and 3 minutes. Imagine how important that is for our patients that are acutely nauseated or are having pain. Inhalation, I believe, is a more effective delivery system for THC than oral agents. It allows for near immediate results, self-titration based on puffing behavior, more control over dosing, and there's no oral tolerance requirement because it is not a pill. Are you opposed to smoking? Most of us are. We've kind of been raised that way. Smoking is bad. Well, there is an alternative. It's the vaporizer. Crude marijuana is placed inside of this machine. It's heated up to 120 to 170 degrees, and the cannabinoids are vaporized and then stored in this reservoir. You're not getting any of the products of combustion. And the plasma THC levels with smoked marijuana and vaporized marijuana appear to be similar, as shown on these graphs. So in conclusion, marijuana does have medical value. I believe it's misclassified as a Schedule I drug. It's relatively non-toxic, has a low addiction potential, and inhalation is an ideal route of administration. I'd like to finish with a quote by Ethan Nadelman. Our obligation, particularly as physicians, is to uproot our fear and actively fight for drug policies that are grounded in science, compassion, health, and human rights. Thank you, guys.
Good morning. I first want to say, no, I'm not the bouncer, nor am I a cop. I'm actually one of the graduating third-year residents from McCady Hospital. I am from the area. I grew up in Roy, Pleasant View area. I went to medical school at Midwestern University in Arizona, and I will be sticking around the area as I will be working for Syracuse Intermountain Clinic. To start off, I have no disclosures to make other than I do want to make a statement that there's no other place I'd rather be on Friday the 13th in front of all of you esteemed colleagues giving this presentation. As physicians, we all have those patients or cases that stand out in our minds that are forever burned into our hearts or minds for various reasons, and I've chosen to share one such case this morning. Approximately 2 months ago, while moonlighting in a rural emergency department not far from here, a call came in stating that a 22-year-old male was found down, not breathing, by his fiancée. And EMS was on the scene, coding him, and he arrived 15 minutes later in full cardiac arrest. The patient was rapidly intubated upon his arrival, and CPR was continued per ACLS guidelines. This is what was shown on his monitor. He was in asystole and never developed a shockable rhythm in the field, nor during the remainder of this code. EMS, upon their arrival, gave their report of possible ingested substances per his fiance's account, in that he ingested 6 hydrocodone 5 milligram tablets, 4 cyclobenzaprine tablets, and some alcohol. Once this was learned, he was immediately given naloxone, actually on 2 different occasions, with no results. He was coded for an additional 22 minutes in the ER and, as stated, never gained a pulse or shockable rhythm. The code was called as his family was arriving to the emergency department. His young mother, around 4 years of age, his young fiancé, and his only sibling, his 17-year-old sister. This is what the patient took, as stated, and this was his serum alcohol level after the code was called once the labs were back. So he was greater than 3 times the legal limit of alcohol in the state of Utah. His urine drug screen came back positive for opiates only, and this was his blood gas upon arrival, which was awful. He was given multiple amps of sodium bicarbonate as well without any improvement. Now, I'll never forget the scene as I walked out to the waiting room of that small ER. His family, as stated, his mom, his fiancé, and his sister were the only individuals in that waiting room. And I debated whether or not to deliver the news prior to the social worker arriving, as he was still en route. He was about 10 minutes out. So I quickly came to a solution and decided that the appropriate thing to do was to go out there and inform them. So as I exited the emergency room into the waiting room, again, I'll never forget the scene. His mom, his sister, and fiance looked at me with bated breath, just waiting for what was next. How was he doing? And that's what they asked me. And I sat down next to his mom and put my hand on her knee and asked them to introduce who they all were, and caught them up to speed quickly on what had occurred, that he was found down. His fiancée confirmed she had found him, and what he had ingested. She said he had been drinking, but he normally doesn't drink. He's not suicidal at all. And got them up to speed that he never had a pulse in the field. We coded him. We worked on him. But I'm sorry to inform you that he did not make it. And the utter shock and, as you can imagine, disbelief, sadness erupted as I stood there trying my best to comfort them. To make the case even more sad, 2 days prior, he saw his primary care physician after 5 days before that being involved in an MVA with his young family, his fiancée and his 1-year-old son. They actually brought the 1-year-old child to see the primary care physician because they were concerned as he was involved in this accident. The patient stated that he had some neck pain, and so his primary care physician suggested that he check in as well, and so he could take a look at him. So he was ultimately diagnosed with cervical strain, whiplash injury, and prescribed those medications. I saw his primary care physician as he came through the ER that morning, later that morning for other reasons, and informed him of what had occurred, and he was in shock as well and said that he had seen him 2 days before and considered him extremely low risk, that he knew the family very well and was aware that he drank some alcohol but considered him low risk. Prescription drug abuse has been classified by the National Institute on Drug Abuse as the intentional use of any medication in a way other than prescribed, without a prescription, or using for the experience or feeling that it causes. According to the CDC, prescription drug abuse is the second most common cause of accidental death in the United States, second only to automobile accidents. Prescription drug abuse far outweighs deaths, more deaths than gunshot wounds or homicide. In 2009, an astounding 7 million individuals reported using psychotherapeutic drugs in a non-medical manner over the past month. This is nearly 3% of the U.S. population. Prescription narcotic abuse is classified as a modern-day epidemic and is running rampant in our nation. It is the fastest form of substance abuse, the fastest growing form, and is second only to marijuana use across all age groups. During 1999 to 2006, the number of deaths in the United States due to poisoning nearly doubled, and this coincides with a greater than fourfold increase in opioid prescriptions given nationally. The increase is also further classified by an increase in the deaths involving prescription pain relievers, as this more than tripled during that same time period. Opioids prescriptions increased from 45 million to nearly 180 million and accounts for a significant amount of emergency department visits for problems relating to non-medical drug use. Here's an interesting statistic. Hydrocodone acetaminophen was by far the most commonly prescribed analgesic of any category in the U.S. over the past 6 years, and generated in 2008 $1.8 billion in retail sales, and was the top-selling generic drug. This graph further demonstrates the prevalence of pain relievers in initiates of illicit drugs. In nearly 3 million initiates of illicit drugs, prescription pain relievers came in second only to marijuana. And it's important to note that prescription pain relievers account for more than the rest of these combined, which is fairly astounding. This graph shows the rate of unintentional drug overdose deaths in the United States during 1970 to 2007. As you can see, from 1990 to 2007, this rate has almost quadrupled. This graph breaks down state by state prescription drug overdose death rates. And as you can see, Utah is third, only to West Virginia here and New Mexico. So we can hang a bronze medal on the state of Utah for our efforts. This is a race we would obviously like to finish last place. Who's at risk of dying from drug overdose? Well, men are at greatest risk. In fact, nearly twice the risk that of females. And this is thought to be that there is a higher substance abuse rate in males overall across all age groups. Important things to point out is the age range 45 to 54. This is the highest rate in both sexes. And this is also congruent with increased risk during the same age range for prescription drug abuse. Other important age range is 75 to 84, as this is the lowest, because it is also thought that this is the group that is the lowest risk for prescription drug abuse. Where are these individuals getting their drugs? Well, according to the National Survey on Drug Use and Health, in 2007 and 2008, a survey was performed on individuals 12 years and older who admitted to using analgesics at any time during the previous year. 20% obtained the most recent medication with a physician's prescription, with 56% obtaining them from a friend or relative, i.e. the medicine cabinet. 19% got the medication each time from a single physician. A very small percentage got them through the internet, and nearly 5% bought them from a dealer or other stranger. A separate study suggests that nearly 5.2 individuals reported non-medical use of prescription analgesics the previous month. Another astonishing statistic is 1 in 10 high school seniors abuse prescription painkillers, according to the U.S. Drug Enforcement Administration. Why do these individuals abuse prescription narcotics over other drugs? Well, it has been postulated that prescription drugs are perceived as being more socially acceptable to abuse. They're perceived as being safer overall. After all, they're prepared by pharmaceutical companies. We as physicians prescribe them, thus it can be more justifiable, and doses are more predictable as well. Prescription narcotics are also easier to obtain than our illicit drugs and can be accessed through safer means. One can simply walk as far away as the medicine cabinet rather than having to traverse the slums and dangerous neighborhoods and risk their life in obtaining their drug. Screening for prescription drugs poses a challenge because standard urine immunoassays for opioid drugs of abuse detect an antibody against morphine, and positive results are triggered after only threshold concentrations are reached. Those opioids that are metabolized directly to morphine, such as codeine and heroin, are readily identified by these tests. However, semi-synthetic opioids, such as hydrocodone and oxycodone, have variable detectability because they're not metabolized to morphine and generally will not test positive at conventional doses. Synthetic opioids such as fentanyl and tramadol have virtually no cross-reactivity. Therefore, separate, more expensive testing has to be performed, and most insurances do not cover these tests. I don't profess to have the answers to curbing prescription drug abuse in the nation, as it is a rampant problem. However, what can we do as physicians to decrease the risk to ourselves and our patients? Well, the CDC has several recommendations. First, we should prescribe opioids only after alternative therapies fail to deliver proper pain relief, and we should start with the lowest effective dose. Do not prescribe long-acting or controlled-release opioids for acute pain. Stay away from the oxycodone and fentanyl patches. In addition to screening our patients for risk assessment and entering into medication management agreements, we should also consider performing periodic random targeted urine testing for opioids or other drugs of abuse in any patient that we are going to treat with opioids longer than 6 weeks, or in any patient younger than 65 with non-cancer pain. If the dose has to be increased beyond 120 morphine milliequivalents per day, and we are not seeing substantial improvements in both function and pain, we should be seeking consultation from a pain specialist. And lastly but not least, we should be requesting the report from our state prescription drug monitoring program, and here in the state of Utah, that is the Division of Occupational and Professional Licensing. What's on the horizon? Well, as recently as 3 weeks ago, the FDA unveiled their plan to help stop prescription drug abuse, in that they are requiring pharmaceutical companies of these longer-acting opioids to produce new educational materials for both patients and physicians about their extended-release painkillers. The AMA released a statement on this, stating that overall, the organization supports the intent of this program. However, there's a concern with mixing industry and medicine, and there's the fear that this will become a mandatory part of the DEA registration process for all physicians. Going back to the patient I presented in the beginning, as I mentioned, I'll never forget that experience, and I hope that I never have to go through it again. I'll never forget the shock, the pain, the sorrow of having to inform his mom, his fiancée, and his little sister that he was no longer there. This has affected me greatly, and since that time I have taken an extra minute with my patients that I do prescribe muscle relaxants or pain medicines to, and inform them that they should not consume any alcohol at all, as this can be fatal. And I have personal experience. I've seen it. As physicians, I hope that we all can do our part to help minimize the risk to not only our patients but to ourselves. Thank you very much.
Hi, I'm Carissa Monroy. I am a third-year resident at McKay-Dee as well, and I did my medical school training at University of Utah, and I will be staying in the area. I'm going to be working at the Clearfield Midtown Community Health Center starting in September. And I think it's really interesting to see how different all of our presentations are today. This is a little bit of a different subject than what we've been talking about before. I'm going to be talking about breastfeeding in the Ogden community. So my interest in breastfeeding comes from a few different sources. First of all, I'm a primary care provider, family physician, and I see women prenatally, and I also see their infants afterwards. And I also have a master's in public health that I got with my med school degree. So I have an interest in how these in subjects that affect the greater public health of our communities. I feel like I'm an advocate for women and children. And probably my interest became most prominent when I became a mother myself. I had my first child at the start of my second year of residency. And when I became pregnant, I said, I don't know if I'll breastfeed. I will if I can. And some fellow residents and faculty told me how important it was. And the more I looked into it, I thought, well, if I didn't know, perhaps many of my patients don't know. So that really prompted my interest. And besides these interests, I have nothing else to disclose. So my objectives today, I'll be talking first about the benefits of breastfeeding, then talking about recommendations for breastfeeding, then I'll talk about breastfeeding rates, barriers to breastfeeding, and the role of the provider. And then in those latter three, I'll be incorporating a quality improvement project I did at McKay-Dee. So what are the benefits of breastfeeding? We know there's direct benefits to the infant. Antibodies are passed from mother to child. And this leads to decreased illnesses. And this even occurs when the infant is in group daycare. Here are some specific diseases that they've looked at. This chart is quoted often. Sorry for the problem there, but this chart is quoted often in different books and in different articles, and this comes from multiple different studies. But you can see that there's multiple different diseases that there's an increased risk if an infant is formula feeding instead of breastfeeding. Otitis media and gastroenteritis are consistently shown in the literature. And then here, I know this is kind of a busy slide, but you can see there at the bottom, in the developed world, there is a 3-time increased risk of hospitalizations in infants who are not breastfed. And then you can see the huge difference in morbidity and mortality in the developing world. There are also benefits to the mother. She has fulfillment from physical, emotional connection with the infant. She loses her pregnancy weight more quickly. There is a decreased risk of ovarian and breast cancer, but that only is if the mother breastfeeds for a long period of time or starts earlier. The Women's Health Initiative also showed a decreased risk in cardiovascular disease. It can be used as a form of birth control, and it also can save the woman money or the family money. They've estimated about $1,000 per year, and that doesn't necessarily include illnesses that the infant might suffer from. And of course, benefits to the community as well. There's been estimated savings of $3.6 billion. There's a decreased cost of WIC. There's decreased parental absences from work if they don't have to take care of sick children at home. And then there's a decreased environmental and energy burden. So what are the recommendations for breastfeeding? The American Academy of Pediatrics recommends that physicians should recommend breastfeeding to all of their patients. Supplementation should not be given unless ordered by the physician. They recommend exclusive breastfeeding for 6 months and then continuing to breastfeed for 1 year or beyond as desired by mother and child. And they recommend that the infant is seen 3 to 5 days after birth if they're being breastfed. The CDC has also approached this subject. They created an initiative in 2000 called Healthy People 2010, and this addressed multiple different public health issues, and one of those was breastfeeding. So they made specific goals for the country to reach on breastfeeding in infants. And you can see we have data only up until 2007 that I could find. And by 2007, we had met the goal of 75% of infants who were ever breastfed. We still have lower numbers of infants who are breastfed at 6 months and infants who are exclusively breastfed, and we still haven't met those goals, at least as of 2007. This is a map, again, another map, and this time it's showing breastfeeding percentage at 6 months. And you can see that Utah is doing quite well. The dark blue states are the ones that are doing more than 50%, or more than 50% of infants are breastfed at 6 months. This is a graph comparing Utah to the United States, and Utah is in red. And you can see overall Utah is doing better than the national average. And the percentage of infants who are ever breastfed is actually close to 90%. And we do have higher rates of breastfeeding at 6 months, at 1 year, than exclusive breastfeeding. That last graph on your right is actually not a good thing to be higher on. That's the percentage of infants receiving formula at 2 days of age, and that's negatively associated with breastfeeding duration. And I know that you might think, well, that association doesn't prove true here, because in Utah we have higher rates and we have more infants receiving formula. But what that says to me is that we could probably do a much better job if we decrease the amount of formula given immediately postpartum. So my project, I did a survey on the postpartum floor at McKay-Dee Hospital over a 2-month period. I'd had surveys available in English and Spanish, and I had over 100 given out in English and had 32 returned. And then the interesting thing was that I had none completed in Spanish and actually had none of them handed out in the end. And when I questioned this, the nurses said they didn't feel comfortable explaining the survey to their Spanish-speaking patients. So this gave me data right there saying that if they're not discussing the survey, they might not be discussing breastfeeding with these patients who are at risk. So what were the rates in Ogden? So 91% of women are breastfeeding and 9% are doing formula only. And this is going back to that chart I showed earlier. The blue graph there is the United States, red is Utah, and green is Ogden. And you can see we're pretty similar to the rates in Utah, and doing well on the percentage of infants who are ever breastfed. This is breaking things down further into what percentage of infants are breastfeeding only and what infants are breastfeeding and doing formula feeding. You can see 53% are breastfeeding only, 38% are doing breastfeeding and formula. So then we compare this again to that last part of that graph, and I said this is a negative one to be higher on. You can see that in Ogden, 38% of our breastfed infants are receiving formula in the immediate postpartum period. And again, this is associated with a decreased duration of breastfeeding. So we'd like that number to be lower. And I just stated that right there. I did also ask the women what their plans were for breastfeeding at discharge. 53% of women were planning on breastfeeding exclusively, but this wasn't the exact same 53% that I was showing you in the previous slides. 4 of these women were actually giving their infants formula in the hospital. So they're planning on exclusively breastfeeding, but still giving formula in the hospital. So that's maybe not giving them the best chance to proceed with their plans. And I did have one woman report that her infant received formula when she didn't want her infant to get it. So just brief conclusions from the breastfeeding rates part of it. Our community does have high rates of breastfeeding, but we also have higher rates of formula given in the immediate postpartum period, which may decrease breastfeeding duration. So what are some of the barriers to breastfeeding? These are commonly stated barriers, one of them being lack of education, as I mentioned before, that my thought that there wasn't that much of a difference, but that idea that formula and breast milk are equal. There's physical discomfort in the initial postpartum period, oftentimes lack of support, including lack of support from healthcare providers. And then you often hear women say they don't feel like their milk has come in. Other issues are going back to work or school. When the mother has medical problems or the infant has medical problems, this can make it difficult. And then the last part, formula promotion, is another issue. It's very difficult to do randomized controlled trials with breastfeeding for obvious reasons. But one study that was done, women were randomized to either receive formula, like a parting gift when they were discharged from the hospital, or they did not receive formula. And those who received formula were much less likely to be breastfeeding when followed up afterwards. And that was a statistically significant finding. This is just another way to look at it. What things are positively associated with breastfeeding duration? So some of the maternal factors, an earlier decision on planning on breastfeeding, higher education, being married, and then some of the hospital practices if we initiate breastfeeding earlier in the postpartum period, rooming in that early skin to skin. And then the encouragement from a healthcare professional. And then negative factors include obesity, depression in the mother, the perception of a lack of support, and then hospital practices, again, I mentioned that use of formula during the immediate postpartum stay and formula samples as well. So what did I find in my study with barriers to breastfeeding? I did ask all the women who were formula feeding why they were not breastfeeding, and one said just because it had never worked for her, her babies didn't like it. One woman, her baby's in the NICU, and the other one did not give a reason why. And then I tried to pair out some of the groups who are at risk for not exclusively breastfeeding. So that graph on the left is blue. The blue one is the 53% of women who are exclusively breastfeeding in the hospital. And then you can see that there's first-time mothers, single mothers, minorities, and women who had a cesarean section are all less likely to be exclusively breastfeeding in the hospital. And then right there at the end, there's supposed to be a graph for the NICU. None of the women with babies in the NICU were exclusively breastfeeding, which I think is understandable. And then this is showing barriers to planning on exclusively breastfeeding at discharge. And this isn't quite as drastic. And I added in an extra group there, the less educated, which is that blue graph. All of these women, though, are less likely to be planning on exclusively breastfeeding. And I do think the NICU data is a little more applicable here because I think there are many babies who stay in the NICU who could exclusively breastfeed when they're discharged home, but the mothers perceive that that's not a possibility. And so we have found that our community does have similar risk factors for not exclusively breastfeeding, and we still need to gather more information from the Spanish-speaking mothers in our community. And so last thing I wanted to talk about was the role of the provider. Healthy People 2010, that initiative I mentioned earlier, specifically stated that lack of support from the healthcare professionals is a major barrier to breastfeeding initiation and maintenance. There was a study by Humanic where they looked at first-time moms, and if their healthcare provider had suggested supplementation, they were less likely to be breastfeeding or to decrease the amount of breastfeeding. And they also found that only 25% of providers were discussing breastfeeding at the postpartum visit. And this is what I found in our community. So here I've separated male and female providers. But there on the left, you can see what percentage of providers discussed breastfeeding prenatally. And overall, amongst all the providers, that was less than 50%, at least in the patient's minds, that's what they perceived. And you can see maybe males doing a little bit better there. And then I also asked the question, does your provider encourage breastfeeding? These numbers were higher, and I think that's because in patients' minds, they were thinking about the postpartum period as well. And you can see that we're about 60% of providers are encouraging breastfeeding, and maybe women are encouraging that more than men. I also looked at different specialties. The blue is obstetricians, red is family medicine, and the greens are nurse midwives. And again, it looks like perhaps family medicine is discussing breastfeeding prenatally and encouraging it more than their counterparts. So what should we be doing as providers? If we're prenatal providers, we should be discussing breastfeeding at the first visit and then every visit thereafter, or not every visit, but subsequent visits as needed. I think it's important in that first visit because, as I mentioned on that previous slide, an earlier decision to breastfeed is associated with longer breastfeeding duration. Also review reasons why they perhaps stopped breastfeeding or didn't want to breastfeed previously and see if you can help them work through those. And then try to avoid advertisements for or promotions for formula in your office. We can do things in the hospital. These are all things that we're trying to do, but I think as providers we can try to encourage our patients to do all of these things, have their infant room in with them, encourage on-demand feeding, try to avoid pacifiers or bottles. And then if you have an infant who's staying in the NICU, try to involve yourself with the mom on encouraging her to do what she can to breastfeed her infant. Supplementing is something I've alluded to a few times, and it's something I think we need to be decreasing. The reasons why is because it decreases the mother's confidence in her milk supply, and it actually does decrease her milk supply because it's less time that the infant is suckling at the breast. It creates nipple confusion, and sometimes will create a preference for the bottle. And in general, it's not necessary. And if it is, there are other non-bottle methods that you can offer. Jaundice is another one. You often see infants who are given supplementation when they have jaundice, but the American Academy of Pediatrics specifically recommends against supplementing in infants with jaundice, but leaves that decision up to the provider. So you do have other options to monitor the baby's intake and output and try to evaluate for lactation difficulties. So the hospital where I did this isn't officially baby-friendly yet, and that, I think, is related to some formula company influences and some expectations in the community to receive things when they leave the hospital. And so I think that's something we could possibly change on a policy level. We do have good rates of breastfeeding. We've seen that, but I just think, again, we could be doing so much better, and I do think our at-risk population could really benefit from changes in regards to this. And, of course, you can involve yourself with your patients if they're very motivated to breastfeed and try to work with her nurses in the hospital to get her to do that. In postpartum care, it's important, as I mentioned before, to follow up 2 to 4 days postpartum, evaluate lactation. You do have access to lactation consults after discharge. And then make sure your patients are educated on the recommendation for exclusive breastfeeding for 6 months and continuing for up to 1 year. I don't think a lot of patients know that specific recommendation. And it's also important that when we say exclusive breastfeeding until 6 months, that means not giving the complementary feedings that we often start at 4 months. And the reason why is because that does not increase the total caloric intake, and it does not increase growth, and you're only substituting calories for food that lacks the benefits of human milk. And then I know there's controversy with the vitamin D, but the AAP does recommend that the infants who are exclusively breastfed receive vitamin D beginning soon after birth. So going back to my study, I just wanted to finish up discussing some of the limitations. There was a selection bias. It's most likely that women who filled out the survey were probably more likely to be breastfeeding, so the rates could actually be lower than what I found. There is a lack of data from the non-English speaking population, and I think it's important to look into that. We had a small number of participants, and so we had a small number of participants, so if we can only look at trends, we can't really say this is statistically significant. And this doesn't give us any long-term data. We don't know breastfeeding duration. So in future studies, I think we could follow up with some of these women specifically and see how long they breastfeed for and look at barriers that perhaps prevent them from breastfeeding. We could try to do further studies with that Spanish-speaking population and then try to look at perceptions of breastfeeding amongst the providers in our community. So in conclusion, the things we found, again, most women are breastfeeding in the initial postpartum period, but many are also giving their infants formula, which may lead to a decreased duration of breastfeeding. and it does not meet that goal of exclusive breastfeeding that we're trying to reach. First-time moms, minorities, single mothers, less educated women are less likely to be exclusively breastfeeding and planning on doing so. Physicians of both sexes and all specialties can improve at discussing breastfeeding prenatally and encouraging breastfeeding in the hospital. And we know we need to improve communication with our non-English speaking patients. And that is all I have. Thank you.
Good morning, everybody. My name is Chuck Richardson. I'm one of the other third-year family medicine residents at McCady Hospital, and I'm privileged to be able to join the family medicine group in North Ogden from Intermountain after we graduate, assuming Greg lets me graduate. Where are you, Greg? Okay. Today I'll be speaking on patient motivation to compliance and the doctor-patient relationship. I, first of all, have no financial relationships other than the dysfunctional relationship I have with my lender for my medical school loans, or conflicts of interest to disclose today. To outline my topic, I'll first be speaking about the impact of patient noncompliance and some prevalence. We'll discuss some causes of noncompliance and associated studies, and then I'll present a local survey that I performed in some clinics in the community that target the association between the doctor-patient relationship and medical noncompliance, after which I'll discuss some clinical implications and possible areas of intervention. So I have wondered many times in my clinic whether my patients belong to a group that goes by this theme: recovery begins with noncompliance. There have been studies that have looked at this, and the estimates that are out there say that across the nation, noncompliance is as prevalent as 25%, meaning that 1 in 4 of our patients that we see during the day is likely not to listen or do what we say. This increases in some disease conditions and clinical settings, specifically pulmonary disorders, sleep disorders, and others. There are a number of different medical fields which have been studied, where this has been studied, most of which have been primary care settings, but there have been several specialties that have been involved in these types of studies as well. A number of different diseases have also been involved, most of which have been chronic diseases. So in my review of the literature about noncompliance, it became very evident pretty quickly that this is a multifactorial process, as one would assume. Some significant proposed factors include the patient's belief in disease threat, rated health status by the patient, objective disease severity, absence of symptoms, normalization of symptoms, side effects of treatment, and finally, many aspects of the doctor-patient relationship. It is on this last topic that I'm going to spend the remainder of my talk today. In 2007, Fuertes and his colleagues studied 118 patients with varied chronic medical conditions. Their goal was to determine whether there was an association with the varied number of aspects of the doctor-patient relationship that they termed the working alliance, and the following 4 factors: patient perceived utility of treatment, patient perceived adherence, objective compliance, and then patient satisfaction overall. What they were able to find was that there's a moderate to strong positive correlation between the working alliance, as they termed it, and patient perceived utility of treatment, perceived adherence, actual compliance, and then patient satisfaction. Furthermore, they performed regression analysis to look at causal relationships. They were able to find that ratings of the doctor-patient relationship, as well as patients' perceived compliance, was actually able to predict whether or not those patients complied to medical treatment and how happy they were doing it. In 2009, Haskard and DiMatteo performed a fairly significant meta-analysis that spanned approximately 60 years of investigational research. They included 106 correlational studies and 21 experimental studies, and they looked at specifically the relationship between physician communication and patient compliance, as well as intervening and teaching doctors how to communicate and what that did to compliance. They found, again, with the doctor-patient relationship and specifically with physician communication, that there was a positive correlation between communication and compliance, and suggested that there was a 19% higher risk of noncompliance among patients whose providers had not been educated more formally in communication skills. What that works out to be, at least in 2005 data, is approximately 183 million doctor visits in that 1 year. Furthermore, they were able to show that training physicians in communication skills was able to cause a significant improvement in patient compliance overall. They suggested that patients whose providers were educated in communication skills were over 1.5 times more likely to follow their provider's advice than if their providers had not been trained. And this implies that not only is the doctor-patient relationship important, but that physician-patient communication is highly correlated with increased patient compliance to treatment. And more importantly, communication with our patients is one area over which we as providers have influence in improving our patients' compliance overall. So with this understanding, I performed a local survey with a hypothesis that there's a disconnect that exists between the patient's values in the doctor-patient relationship and our perception of those values. And not only that, but that this disconnect contributes to noncompliance overall. I sought to answer the following 3 questions. Which aspects of the doctor-patient relationship were most important in motivating our patients? Which of those aspects do we as providers perceive to be the most important for patients, and how do those 2 reports compare? I employed 2 different surveys to discover this disconnect, and the first of which I'll discuss today was a simple survey used only in the residency clinic at Porter Family Medicine. I asked 1 question, and that question was, how often do you, or in the provider's instance, your patients follow your medical advice? They were given 4 options: always, most of the time, some of the time, or never. Simplicity makes me happy. So what we're able to find here, these results are shown with the patients in blue and with providers in red as percentages of the total. We already see that there's a disconnect between our patients' beliefs and our own beliefs. Over 60% of patients felt that they followed our advice all of the time, with the remainder choosing most of the time. We, as providers, were much more skeptical. Over 55% of us felt that, at best, our patients followed our advice most of the time, with the remainder of us feeling that it was sometimes. The second portion of the survey was performed at 2 different clinics, our residency clinic as well as the local community health center at Midtown Clinic. I provided separate patient and provider surveys and handed them out. They had each contained a list of 8 values related to the doctor-patient relationship. The patient surveys were given out in both English and Spanish and were anonymous, and the provider survey, although it was not anonymous, did reflect or mirror the questions given on the patient survey. The question that I asked both providers and patients was, which do you believe is the most important factor in motivating you or your patients to adhere to medical advice? The values that were listed below were as follows: amount of provider knowledge, provider's ability to listen and communicate with patients, fear that the disease will worsen if the advice is not followed, whether or not the patients were allowed to participate in the plan of care, relief of pain and suffering, provider's coordination of care, provider's respect for patient beliefs, and finally, cost of treatment itself. These values were ranked by both patients and providers from 1 to 8 in descending order of importance as to how they motivated patients to comply with treatment. We had a total of 200 patient surveys returned, and unfortunately, I'm finding a common thread from Carissa's talk, only 61 of these were able to be interpreted. That left 70% of patient surveys that were returned unable to be interpreted because they weren't filled out correctly. 26 total provider surveys were returned, and all of these were able to be interpreted, fortunately. The most and the least important values for both patients and providers were analyzed and then aggregated for each clinic and then are combined, and the results are shown on the following slides. This slide shows the most important motivating value by patients in blue and providers in red. This is demonstrated as a percentage of the total number 1 rankings by motivating value. The first thing that we are able to see is that patients, over 45% of patients, felt that listening and communication was the most important value for them when it came to following their provider's medical advice. As providers, we were more varied in our responses. Almost a third of providers felt that relief of pain was most important, while another third felt that patients' participation in care was most important. This was followed closely behind by listening and communication for providers as well. In a similar fashion, the least important motivating value was evaluated and is shown here. Again, with patients in blue and providers in red. We see first that as providers, we felt that our amount of knowledge was the least important motivating factor getting our patients to comply with treatment. Given the two clinics, this next point is fairly interesting. Over 50% of our patients felt that cost was the least important motivating value as far as following their provider's advice. There are a few points of comparison to discuss between the two clinics. First and foremost is that patients between the two clinics agreed with each other. Each clinic felt that the most important value was listening and communication, and that the least important value was cost. When looking at providers, we were again varied in our responses. At the Community Health Center, most of the providers felt that patient participation was most important, whereas residency participants felt that the relief of pain was most important. The one thing we did agree on, though, was that our amount of knowledge was the least important motivating factor for our patients, which is interesting given the fact that it's the second highest, most important value for them, at least in this report. And there are some obvious limitations to this study. Over 70% of the patients' surveys were not able to be interpreted, which likely speaks to a design in the survey, or flawed design in the survey itself. There are small sample sizes for both patients and providers. Populations of both clinics are similar to each other, but may not be similar to everybody else's clinics. Over half of the provider surveys which were returned were from residents, which may speak to some experience bias overall. And then finally, these findings obviously represent possible trends only and not necessarily statistical significance. Given these limitations, however, I think this simple survey demonstrated a few important points. First of all, there is a disconnect between our patients' values and the doctor-patient relationship and those perception of values from our standpoint. This disconnect is likely contributing somewhat to noncompliance, but we don't know that because I didn't study what actual noncompliance was in this area. So there's more room for study in applying this to other clinics as well. I would recommend that the further investigation focus on patient-perceived and actual compliance before and after intervention. I will mention two of these interventions that have been studied in the literature. First of all, Lugabani in 2004 suggested using a stages of change model, much as we would use to help our patients quit smoking, and motivational interviewing techniques to help and target our low compliance patients to a better level of compliance. Furthermore, as I alluded to earlier, DiMatteo and Haskard showed that by intervening at the provider level and actually educating providers on better communication skills, that patient compliance improves significantly. They suggested using broad-based intervention for both practicing physicians and physicians in training, targeting verbal and nonverbal communication skills, as well as skills using affective and psychosocial behavior and task-oriented behavior to help our patients learn compliance. They also recommended using active patient involvement in the training process, which is always a fun thing. There are potential benefits that I have listed up here, not the least of which is the doctor-patient relationship and improving it if we're able to improve our compliance overall. Possibly patient health outcomes, certainly provider and patient satisfaction, and may even be some room for some improvements in income and clinical costs and workload. In summary, patient noncompliance is a prevalent problem. There have been many causes suggested and studied, and the survey that we were able to perform was in concordance with some of those studies which had been done before. That doctor-patient relationship is significantly involved in this process of patient compliance. We were able to show that there is a disconnect between patients and providers overall when it comes to those values, and that patients do value good physician communication. Physician communication, lastly, is one area that we can target to improve our patients' compliance and hopefully measurable outcomes for not only them, but for ourselves in the end. I appreciate your time. Here's a list of my references, and we'll be happy to answer questions afterwards. Thanks.
That's not it. So I'm Jesse Spencer, also one of the third years. Happy to be able to speak to you today, kind of wrap things up as far as our residency goes. I'm originally from Salt Lake, suburbia, Riverton there, and it's the Dabigatran one, Dabigatran case studies. Happy to be here in Ogden. Really liked our time up here. I did my med school in Denver, and been here for the 3 years. We'll be going to Richfield. A little bit sad about moving the area because we've liked it so much, but looking forward to moving down there and doing kind of the small town thing for a little while. So this, what's that? Dabigatran case study? I've got it on my drive. You want me to bring it to you? All right, so this is me. I make a terrible-looking Emily. So, Dabigatran is one of the new oral anticoagulants, and we've seen a couple cases come into to McCady that kind of highlight some of the issues that are going to be facing us with these new oral anticoagulants. First off, I guess disclosures. I don't have any financial disclosures. One disclosure I do have is that I was trained by many of you, and if I do misspeak, feel free to slug the person next to you so that we can spread the blame a little bit. I'm also post-call, so you can probably expect to be slugged, and I apologize about that. So an overview, start with a case study, and then talk about some of these new oral anticoagulants, particularly Dabigatran. We'll talk about the mechanism of action, some pharmacology and pharmacokinetics, and then a summary. So I actually had a couple studies, but we're only going to be able to do one because of time. So case study number 1, 83-year-old gentleman who, pretty healthy for his age, diagnosed with atrial fibrillation 5 months ago. He was placed on warfarin at that time. He also has a history of blood pressure, hyperlipidemia, and a titch of chronic kidney disease. He is interesting because he actually switched from warfarin to Dabigatran because for some reason with his insurance it was more expensive for him to go in and get the INR checks than it was, and his insurance covered Dabigatran well. So we actually switched because of cost, which is a little paradoxical. At the time of switching, his creatinine clearance was 1.6. His GFR is 41. Renal function is very important in these new oral anticoagulants, and we'll talk about that. So he comes into clinic 2 weeks after starting the Dabigatran, basically complaining of fatigue and chills, and that's as much as you can get out of him. His hemoglobin is 6.2. He's subsequently admitted to the hospital at McCady Hospital. Subsequent labs reveal PTT of 100, over 150. That's the max that the lab does. INR is 4.6. He has some renal failure, likely from his anemia, and some pre-renal failure. So he's quickly given 4 units of packed red blood cells, 2 units of FFP. They think, well, it's likely he's got a GI bleed. He doesn't have a history of melena, but this is likely. So they check his stomach, and he has clear stomach contents, no blood, anything like that. So the thought process at this time is, well, we know that this is likely whatever bleed he has is likely made worse from the Dabigatran. We know there's no reversal agent for this. We'll let kind of time take its course and see how he does. They did consider dialysis, but it's you got to twist an arm pretty tight to get anybody to put in a dialysis catheter with an INR of 4.6. So they just thought we'll just give it some time. On day 2, initially his hemoglobin increased to 8.3, but in the morning was back down to 6.5. He's transfused 2 more units and responds pretty well to this. His PTT is dropping, and early in the morning, GI is emergently consulted after he has a large melanotic stool. They graciously come to the patient's room, do an EGD, and they find that there's some fresh blood in the oral pharynx around the vocal cords. Unfortunately, this time the patient desaturates, he's intubated, and he's taken to the ICU. A short time later, in the ICU, he's given prothrombin complex and factor 7. And they're able to get some labs, and it didn't make that much of a difference. Another EGD is done. The fresh blood is gone, but there is some AVMs that are cauterized and injected. And there's no sign of active bleeding at this time. So day 3, so now he's got 6 units of blood. He's got a couple units of FFP. They've given him just a small amount of fluids as well for his renal failure. And chest X-ray reveals fluid overload. Despite this, he does really well, and he's extubated. His labs are improving. This thrombin time is a new lab to me. It actually was a send-out, so it was done the day before. It comes back in about 24 hours. It was elevated. We'll talk a little bit more about that. His creatinine is coming down as well. And he actually does so well on day 3 that he's able to go back to the intermediate care unit. Days 4 and 5 continues to do well. No further bleeding. His hemoglobin remains stable. And actually he goes home on day 5, feeling quite well. The decision is obviously made to hold off on any anticoagulants at that time. Quick follow-up on this patient. He was seen 2 weeks later in his primary care physician's office after he experienced some diplopia while he was driving that lasted a few minutes. It was suspected that he had a TIA. He's got this atrial fibrillation still, but he's not on any anticoagulants. And then just this week, bumped into him in the hospital again, and the drug company is going to meet with him and discuss his case, interestingly enough. So a few words on kind of new oral anticoagulants, and there's been a lot of fuss about these new anticoagulants, and why is that? Well, warfarin has been the only oral anticoagulant in the United States for 50-plus years. We all know patients on it. We've all seen these patients in the hospital. We all know that there's a lot of risk with this, and I think, frankly, it's kind of exciting to see some new things come out. We're also seeing more and more patients using oral anticoagulants with the aging population and particularly the increase in patients with atrial fibrillation. So briefly, just wanted to mention the two main classes of these new oral anticoagulants. The factor Xa direct inhibitors, rivaroxaban and apixaban, these are still in clinical studies. Actually, you can expect the rivaroxaban to probably be FDA approved at the end of this year sometime. And then direct thrombin inhibitor is the only one that's FDA approved at this time, and that's dabigatran. And that's the one that I'm going to focus on here. So dabigatran is also known as Pradaxa. It was FDA approved in October of 2010. The only indication for its use at this time is in patients with atrial fibrillation for prevention of stroke or systemic embolism. There are multiple studies that show that it's at least non-inferior to warfarin in the treatment and prevention of DVTs. We're going to be seeing a lot of this in the literature, and something that we'll have to pay particular attention to. This is a very enticing drug. It's packaged nicely. It works quick, so you don't need to bridge. You lose that. That's very nice. There's few drug or food interactions, so Miss Jones can make the spinach salad and eat it this time. And there's no anticoagulation monitoring, so we might put the Coumadin clinics out of business, which is sad, but for us it might be good. That gets very cumbersome for both patients and providers. The picture here, it's kind of like candy. It's packaged up very nicely, and the worry is that it becomes an impulse buy, that providers are going to start prescribing this before they know much about it. And that's part of the reason I chose this topic. In fact, recent grand rounds at the University of Utah, they did a survey in October after Pradaxa or dabigatran was FDA approved, asking providers how much they knew about it. Surprisingly, providers were using it. They thought it was safer than warfarin, which it has not been shown to be, and they were using it for indications that are not FDA approved. So hopefully we don't get caught up in the pretty packaging, and we know a little bit more about this medication before we prescribe it. Most of the information that's out now comes from a study called the RELY study, published in 2009 in the New England Journal of Medicine. Basically, It put dabigatran versus warfarin and said, well, which one, it was a non-inferiority study. They said, is this medication going to work as well as warfarin for preventing strokes with atrial fibrillation, non-valvular atrial fibrillation? And actually, it showed that it was non-inferior and actually superior to warfarin. The safety profile was quite similar. The bleeding risk was about the same. It did show a slight increased risk in GI bleeds and myocardial infarctions. However, this with the use of dabigatran. However, the clinical relevance of that is not entirely well known at this time, especially with the myocardial infarction data. They're looking at that a lot closer. So briefly, mechanism of action. We all remember this, and I'm sure have it memorized. The rivaroxaban, the direct 10A inhibitors act there, and the thrombin inhibitors, the dabigatran, right there on the thrombin. When you talk about warfarin, it gets a little sloppier. It inhibits multiple factors here, factors 2, 7, 9, 10, protein CNS. It's just not quite packaged as nicely. I think in medicine we like things to be simple, and dabigatran and rivaroxaban and the like, they have potential for that. So pharmacokinetic comparisons. We talked about the mode of action, bioavailability. Dabigatran is a prodrug, so it's not as bioavailable. The peak action of dabigatran, 1 to 3 hours. So again, bridging could be something that we don't do much anymore. Half-life is 14 to 17 hours. That's also great news. Say you have a patient who needs emergent surgery, doesn't need to be off warfarin or is on warfarin. They have to get off of this, and it's kind of big deal consults. With dabigatran, it might just be, well, you stop taking the medication for 1 day, and you're good to go. Plus, you can start up right on, have the surgery, start back on the medication a day later. You can see why this is very enticing. And the route of clearance, mostly renal and dabigatran, so we'll go over that in the next slide here. Oh, the other thing was the drug interactions, which we talked about. So this is kind of a busy slide. Basically, these recommendations are from the University of Utah Thrombosis Service about renal function. If the patient has a renal creatinine clearance above 50, recommend using either, obviously based after a discussion with the patient, discussing other risks. From 30 to 50, they actually, at the University of Utah, are favoring warfarin. If you are going to use dabigatran, they recommend monitoring the creatinine more frequently. They don't go into detail on what, every 6 weeks, every 2-3 months. That's unknown at this time. Under 30, this has not been studied. In the RELY trial that I brought up, nobody had a creatinine clearance under 30. Interestingly enough, dabigatran has been FDA approved for 75 milligrams twice a day for creatinine clearance under 30. That's not based on any clinical data, so would be very careful with that. And then it is contraindicated with a creatinine clearance under 15. Routine monitoring of labs. Again, you don't have to do that with these new oral anticoagulants, which is one of the bigger reasons people like it. These would be something to consider in an emergent situation. A patient comes into the emergency department or to the hospital bleeding. Real quickly, INR, it can affect it, no meaningful relationship. The PTT, it's nice because it's readily available. Its negative predictive value is nice, but it doesn't tell you anything on the concentration. You can have a very high concentration of dabigatran in the blood and a very mildly elevated PTT. Thrombin time and eccrine clotting times, these are the two labs that I think we're going to come to know a little bit better with time. The thrombin time, right now, it does take a day to get back. At the University of Utah, they're working on that. They'll have a rapid test probably this fall. The eccrine clotting time, I don't even think they do that at the University of Utah right now, but they're working on a rapid test that won't be available until next year. The eccrine clotting time is the one that's going to be most helpful quantitatively. Reversal of dabigatran, again, this was emphasized in the case study. There is no antidote for this, so it's essentially take time. It's nice that it has a short half-life. Unless your kidneys aren't working well, then it's going to take much longer, as I showed with the case study. The most important issue with dabigatran is going to be the reversal. You need to stop the bleed. So these are some kind of novel therapies for dabigatran reversal. None of these really work really well. The prothrombin complex concentrate and the recombinant factor 7A, both of these they're available. They're very expensive, but they don't work that well. FFP is not a reversal agent, may give you a little bit of time, but overall not helpful. Charcoal in the acute ingestion may be helpful. Dialysis, again, would be helpful. It clears 60% of it within 2 or 3 hours. However, you're going to have a hard time finding somebody to place a catheter with abnormal coags. Final points. I think this is a great medication. I think we're going to be seeing a lot about this. It obviously has huge potential. But to stay away from the impulsive buy, we need to educate ourselves more about these medications. We're going to have to become more familiar with these 2 labs, the thrombotime, the ECT. Understand that there's no reversal agent for this, and so choose your patients wisely, and understand that right now it's not shown to be more safe than warfarin, and so there will be inevitable bleeding, and we're going to need to know how to manage that. And again, multiple studies coming out within the next couple of years on these medications, comparing them to each other as well as to warfarin. They all use different labs, and it's going to be a little bit I think it's going to take some time for us to figure out exactly how to monitor these medications and which ones are best for which circumstances. Obviously, decisions should be patient-specific. Very important to educate your patients. Use it only for approved indication, which I discussed already. Very important to monitor the renal function. Obtain a good medical history. If there's any bleeding risks of MI or dyspepsia, you may want to consider warfarin that has a reversal agent. And rifampin is the one medication that does have a drug interaction with dabigatran. These are recommendations again from the University of Utah Thrombosis Service. They recommend if a patient's doing well on warfarin, if it's not broken, don't fix it. Cost, I mentioned that briefly. Coumadin is going to be anywhere between $25 to $60 a month. Dabigatran, $210 to $260 a month, and maybe $100 a month if you're not insured. They initially thought that there was going to be a big influx of people moving to dabigatran, but in these hard economic times, they're finding that the cost has actually become more of an issue, and that people are kind of sticking with the warfarin or the Coumadin now. Chuck talked about it. Patient compliance. You're never going to. It's going to be hard to know which patients are going to be good for this, but again, it takes an honest heart-to-heart discussion with your patients when discussing this. And one idea is turning the Coumadin clinic into the thrombosis clinic, where they can get education, get information on these new oral anticoagulants, maybe get some phone calls quarterly to see if there's any medical issues that would change your decision-making on which anticoagulant to use. A great resource in the community is at the University of Utah. Their thrombosis service has worksheets for providers, education for patients, and, checklists. Does your patient have creatinine clearance of this? Yes, no. Tells you what you should use. A great resource as well as there's some grand rounds that's a video feed online. And that's it. So I guess we'll have you come up and take some questions for a few moments.
We'll take questions until the top of the hour. I'd like to just congratulate these residents. They did a very nice job, very well-researched presentations, and very well presented. Appreciate your efforts, and why don't we give them a round of applause one more time.
That's one of the reasons. The question was, if somebody has vague symptoms like headache or fatigue, do we let that person, and I'm assuming several days after the concussion, do we let those people return to play? That's one of the nice things about impact testing. It helps us kind of tease out the people that are cognitively impaired versus just having a physiological headache or just tired because they didn't get enough sleep and were out partying too late. And so it can be difficult to tease those out, but that's one of the reasons that we use the impact testing. So, I don't know. Who's in charge?
We've got a number of questions. If you don't mind, if you go to the microphones, that's easier for everybody to hear what your question may be, and then we'll know who's available.
Question for Dr. Latica on the marijuana. Any data on children or adolescents or preteens in the home, the likelihood of them using if their parents are using medical marijuana?
I don't have those exact statistics, but I do have, there's quite a few studies showing that states that put medical marijuana on the books did not have an increased use of recreational drug use, but I don't know about in the same home.
I have a question for this same doctor. I've heard recently that many of the states, because of recreational use under the guise of medical use, have began to think maybe they made a mistake by approving it.
I don't know those circumstances, but I think that you'll see through time that more and more states are going to continue to adopt medical marijuana, so that just hasn't been played out. But I'm not sure about the specifics you're talking about.
I have a question over here.
Yes, the doctor who spoke about the patient compliance mentioned stages of change model. Could you explain that for us, please?
Yeah. Is this on?
It will be. Done now.
Yeah, okay, great. So the stages of change model uses a concept of pre-contemplation in patients and then areas. So basically it focuses on whether or not patients are even thinking about changing. For example, with tobacco abuse, do they even want to quit smoking? And it takes them through specific stages of the change to where they finally start accepting that they want to stop smoking. And then for providers, they get involved at different levels. So it's ineffective to start helping somebody to quit smoking, or in this instance, to comply, if they're not really even thinking about that and it's not on their radar.
Very good.
This is for Dr. Monroy. I'm from a county in California with 1.5 million people, and 36% of those are Latin American. And yet, I do not see the publicity that we found in Latin America. The La Leche League was very powerful, very public, and very helpful in Latin America. Why are we not using that resource?
I think we should. Well, I think we should be using it more. There is a La Leche League, I think, in Ogden. They meet one day of every month. And I think that's a great idea to use that more for the Latino population.
Thank you.
Over here.
A couple of questions on the concussion. Why was that student removed from classes? You mentioned cognitive as well as physical rest. Why cognitive rest? Why remove the student from classes?
Well, it has actually been shown that with concussion, a lot of the students that remain in class and use their brains a lot more end up having longer lasting symptoms. And so removing him from class helps that patient to heal a lot quicker. And so that's why he was removed from class, in addition to activity.
And regarding marijuana, you said that there was 1 to 17% incidence of dependence. What is the nature of this dependence?
It's not thought to be a physical dependence because there's no drug withdrawal symptoms associated with marijuana. So I imagine it's psychological dependence.
Dr. LaRose, the gentleman that took the overdose of narcotic and alcohol and so forth, why did he do that?
That's a very good question. I truly wish I could have asked him that, to be honest with you. As I mentioned, his fiancée and his mother adamantly proclaimed that he was not suicidal at all. He occasionally drank alcohol. And my suspicion is that he had the medication there. He was probably in a little bit of pain still. And so he took it, wanted to get a buzz from it, and ended up dying as a result.
Yeah, my concern is not with the object, the Percocet or even the alcohol, but with the why. And do we need to address that more than we need to address the actual medication?
That's a very good question. I believe you're correct in that statement. I think there needs to be more awareness about the why, that we need to talk about drug abuse in general and try to reduce the numbers of prescriptions that are available in homes in the medicine cabinet.
Hi, this is mostly a comment, and this is for Dr. Spencer that talked about dabigatran. For those that don't know me, I'm a gastroenterologist here in town, and I thought I was comfortable listening to your talks until I heard that one, because I know that when I'm on call, I see about 2 or 3 GI bleeds a day with a bunch of those patients on NSAIDs and Coumadin, and I thought I'd just make a comment on how we manage this and how this really does change the game for us. When someone comes in with a massive GI bleed, we can predictably, we have quite a bit of experience with Coumadin and how to manage those patients. But with the development of this new drug and the inability to reverse the drug, it really does affect the way we're able to scope and take care of these patients. You would think you could just cauterize a bleeding vessel, and you can, but when they're INR, when they're coagulopathic and their INR's up, it doesn't ever go well. They bleed a lot more. And you can inject epinephrine, and it's so temporary, you can put clips in, but without the ability to reverse this drug or accurately interpret or know what their levels are very quickly, it makes it a lot more difficult. So I might throw that out there for those that are thinking of prescribing this and remind you that we will, I think, see a lot of these GI bleeds. And thankfully, I wasn't on call the day that case came in. My new partner was, and I could tell from her stress level that it really, really affected her because, she immediately told me, this was just a difficult case without any reversing agent. And when something's bleeding actively in the stomach, if you imagine you're looking through a little teeny fiber optic channel looking at this bleed and blood's bubbling up, you really can't see anything to treat. It's just full of blood and clot. And so it can be very, very difficult. So I might impress upon those that are thinking of prescribing this that really choose your patients wisely and the ones that are at the lowest risk, and they should not be on NSAIDs at all. And if they're on NSAIDs, they should be on high-dose acid suppression. Just a comment. Excellent talks from everybody, and really enjoyed it, and enjoyed working with you this year.
For Carissa, with the breastfeeding in our Spanish-speaking patients, I know we always check the little box, lactation consult, when we do our deliveries, and it sounds like anecdotally those consults rarely get done for our Hispanic patients. I was wondering if the nurses mentioned any of that, or if you talked to the lactation consult any about just our Spanish-speaking population, primarily, if they're getting lactation consults, if the nurses are able to communicate with them that that's available.
Yeah. I think that's a major issue, as I had mentioned before, that many of our nurses don't speak Spanish, and I know that our main lactation consult I don't think speaks Spanish. I think there is one who does, but the one who's there most days doesn't speak Spanish. So how she communicates, I've been in the room before helping to translate when I happen to walk by so I could help, but otherwise I think it's just a lot of actions and trying to help maybe, and it's very, what I've seen has been not as hands-on as I think it should be. So I think that that's something we could work on, and I think with the way our population is changing, getting a Spanish-speaking lactation consult for the hospital would be a great idea. I know we have someone who works in the translation department, I can't think of her name, but she's really a big promoter of breastfeeding, and I know she's available, but it's just not quite the same. And I think you're right. I don't think it's that translation services are being used as much as they should for our Spanish-speaking population.
Over here.
Medical marijuana question. Elsewhere in this conference, in response to a question expressing an opinion about medical marijuana, the speaker's opinion was it's the craziest thing they'd ever heard of. The media has been full of bad press about states who have adopted medical marijuana policies and the lax application of who is a medical candidate for that. Any thoughts as to how to achieve a more realistic view as to the legitimate uses of this medically and how to strengthen the support for that at the same time controlling inappropriate use? Third question then would be, would you review again the status legally of medical marijuana in Utah, where it is versus where it ought to go?
So
I'll start from your last question. The laws in Utah, there's nothing on the books, or that I'm aware of, going to be on the books as far as trying to get legal medical marijuana. And I know that recreationally, Utah, recreational marijuana use, if you get busted, has some of the strictest laws in the country. As far as how to get around inappropriate prescribing of marijuana, I think this is something that we deal with not just with marijuana, but we've heard recent talk about the pill mills in Florida. And I mean, I think just in general, we need to be a little bit better about how we manage legitimate pain or patients that come in illegitimately for pain. And I don't have the answers, unfortunately, but I think that you're making a reasonable case that perhaps there are patients that are prescribed marijuana with questionable medical necessity. I forget the first question. Oh, the officer? He doesn't have a medical degree, and I just think that it was probably just ignorance of the medical indications that he responded that way.
Well, I think people tend to stand on particular issues where they sit.
Yes, indeed.
Over here.
Is it Dr. LaRose? LaRose. Thank you. Thank you so much for your choice of studies. I'm in chronic pain management. That's my specialty. And the why question over here was incredibly insightful, because what I've learned in almost 20 years of doing this is there's a lot more issue with the why than the drugs themselves. And I would like your opinion. Did you look any further than that, or is it just this one specific case study with regard to how prevalent the mixing and the recreational facets of this issue is, and abuse versus addiction? Because in my estimation, abuse is far more an issue than anything that's been addressed in any of these lectures specific to opiates.
Absolutely. I did not look any further into the why in this individual's case, other than talking with his primary care physician, who stated that he actually lives very close to the family, knows the individual very well, and he is in agreement with the fact that he was a pretty straight shooter. As far as concurrent use of alcohol with prescription narcotics, some of the literature I reviewed estimated that approximately 20% of individuals do this, do the mixing of the alcohol and the chronic pain medicines.
One quick follow-up on that. You also mentioned, and I think your slide supports this, so correct me if I'm wrong, in your age group differentiation, there is a huge issue where, and not so much drug availability, but you'll look at your older population, and there's a lot of polypharmacy and a lot of med left lying around. It's not them messing with it. Okay, so again, your why comes into play. It's not so much the med itself as the societal issue. So thank you.
Absolutely, I agree. Thank you. I think, just to reiterate that comment, I think a lot of these medicines end up in the hands of family members of patients who are prescribed these drugs who are not using them. So the caregivers, whether that be daughters, sons, grandkids, they know where to find the medications.
We have a question right over here.
Some of you older physicians may remember a Dr. Charlie Nugent at the medical school. Back in the 60s, he was giving a CPC talk about breastfeeding versus formula. And he showed a lot of statistics that did show it was better. And he said, and besides that, it comes in such nice containers.
This is a question for those of you who didn't hear about breastfeeding and mastitis, of those who get mastitis who should continue to breastfeed.
I think that's a really good question. First of all, I just think, and I'll first point out that there's only 2 contraindications to breastfeeding, and that's being HIV positive in the United States and a baby with galactosemia, and there's absolutely no other contraindications to breastfeeding. But mastitis is an issue. Of course, we encourage when a woman has mastitis that she continues to breastfeed during that time. That will help her get through that episode of mastitis. But for recurrent mastitis, I think that's a really good question, and I wish I had an answer. And if anyone else has an answer to that, I would be happy to hear it. I don't know if you have an experience, but that is a good point.
Brian?
Well, first of all, I'd like to thank the residents for doing a terrific job. I'm very proud of you. Thank you very much for the job you guys did. And secondly, I think Courtney was incredibly professional, given that I tried to set her up asking the question about medical marijuana yesterday, and she did a tremendous job. Carissa, quick question. Do you know if in our population there's a difference between breastfeeding in the Hispanic versus the Caucasian community? My sense is there's a big difference, but I don't know that.
Well, that was what I was hoping to find out, and clearly I wasn't really quite able to find that out. Anecdotally, that was my sense too, that I felt like I was seeing more Spanish-speaking patients who were not breastfeeding, so I was hoping to find that information out. I can say that nationally, Hispanic women do quite well, but also they've done many studies that show that women who are poor, who need to return to work, those are big risk factors, and that's most of the Spanish-speaking population that we see do have those risk factors. Yeah. So I wish we could find that out, and that was my goal, so sorry I don't have that answer.
Study for next year.
Yeah.
And finally, Jesse, do you think the insurance company that chose Dabigatran to save money found out that the bill was a little higher than expected after they used Factor 7 and so on?
Yeah, that's the problem. Yeah.
Okay, question over here.
I don't remember the exact year, but it used to be that when one went on rounds at the hospital, one smelled smoke coming from many of the patient rooms. Laws have gone into effect that people don't smoke in hospitals anymore. Is there any movement to outlaw formula in hospitals, that for the 2 days that the mother and baby are there, that is the sole form of nourishment to the baby, and trying to get that bonding going so that they do have a healthier start?
I think that's one of the ideas behind hospitals who become baby friendly. Obviously, we couldn't outlaw formula altogether, but that was one of the main points I wanted to show in my talk, was that infants are being given more formula than they should be in the immediate postpartum stay. So I don't think we can outlaw it altogether, but I think a goal of making a hospital baby friendly, which means there is much more encouragement for breastfeeding, formula samples not given out at discharge, those types of things, is a move in the right direction, and I think all of Intermountain should probably try to adopt that.
Carissa, I've got 5 children. 3 of them happen to be born at McCady Hospital. My youngest is 5. All 3 of them, within hours of the birth of the baby, were given a bottle and said, "Here, you can supplement until your milk comes in." Yeah. And that was something that just as recently as 5 years ago was at least my anecdotal experience. And then I have a question also for Dr. Latica. So in these states that allow medical marijuana where it is legal, what's the insurance compensation for like that? Is it covered at all by insurance?
It's not covered, and there's other legal consequences. Your employer can still fire you for being positive on a drug test, even if you have a medical marijuana prescription. So there are legal implications, but I have not heard that insurance companies are helping with that at all.
Very good.
But I might be wrong. I just haven't heard that.
Are there any other questions? If not, we'll go ahead and dismiss and join in Ballroom A.